Richard,
Hey
how's your
Mark,
sleep been?
I'm doing well. How's my sleep been?
Yeah, no, how are you doing? But that's a good
Yeah,
question.
I mean, I'm doing great. Thanks, Mark.
Good. Well, welcome to our second podcast. And I'd like to also make an announcement that Barry Rayfield, who you know, is also has been my long time teaching partner as an orthodontist from New Jersey. He is going to be our third amigo, if you will, in our Airway focused podcast, and he will be joining next week. I'm going to be out of town, but you guys are going to go ahead and
Sweet.
run that, so that'll be
Yeah,
great.
I love Barry. I'm really excited about our topic next week. We'll let you guys know about that at the end of today's podcast, but it's going to be amazing. Not going to
Perfect,
want to miss
perfect.
it.
Well,
Yeah.
thanks. Well, what are we going to talk about this week?
Well, I was kind of thinking about a lot of people know what obstructive sleep apnea is or sleep apnea, and they've heard about, CPAPs or, and this only happens to men that are overweight or big neck size, things like that. And first of all, that we know that's not even really true at all. Sleep apnea can affect anyone at any age, but I think what people don't seem to have a really good handle on is what is normal breathing from birth on, and for going forward, what would be considered normal and what kinds of things can happen before someone ends up in sleep apnea. In other words, is there a possibility that someone appears perfectly healthy, but actually has a pretty serious, less overt version of a sleep problem, or not sleep problem, but a breathing problem that will ultimately affect their sleep, but much more than sleep. It'll affect them while they're awake. It'll affect their entire system. And so that led me to think that it would be really great if you could provide us with a little bit of perspective on what is this disease called upper airway resistance syndrome? Who does it affect? What causes it? And what kinds of things would people be experiencing in their own personal lives? What kind of symptomology might they express if they were afflicted with this condition? Because I think that's a part of the breathing airway focus that people just don't know that much about. And they seem to know about the end and they seem to know a little bit about the beginning, but that's that part in the middle that can seemingly baffle people. Why is it that this perfectly healthy professional athlete has a breathing problem and yet they're still really successful? Or why is this college student at Harvard that just got into law school, why are they not at their best? What is it about their breathing that may be impacting them? And I just would like you to talk about how it happens, and what the symptoms are, and then what we can do about it, really. And I think that would be a good discussion. I mean, really, that's like that's the fodder for probably 20 podcasts. But if we
Yeah, exactly.
if we can sort of just focus
Yeah.
maybe on, I don't know, is there a timeline to airway problems? Is there something you can generalize and kind of help people understand a little bit more, both the professionals that are out there listening, but also, our patients, our non-professional people that are
Yeah.
silently suffering.
Yeah. I mean, that's a very rich topic. So there's a lot to cover there, and that's what I'm going to do. Let me start off by first defining what airway is, because there is
Right,
a lot of discussion out there now that the cat's out of the bag, that I think we've reached the tipping point, whereas 15 years ago, when I started talking about this, the focus was really just on sleep and obstructive sleep apnea and appliance
right,
therapy. I mean,
right,
that's where our profession was. Certainly, that's where medicine was. Again, part of that being kind of sidebar, having to do with payment. The medical disease management healthcare system really only open to paying for a disease state versus like preventing a progression. They really largely ignored upper airway resistance syndrome. And so I'll talk about that. But what is airway? So what is airway focused dentistry specifically? And you know, I think it's important in my textbook that'll come out next year. I spent on one of the first chapters defining what airway is. In my opinion, defining it. And airway is not obstructive sleep apnea. Airway is not a palatal expansion. You have a
Okay.
lot of these courses that are out there and these gurus that are out there talking about airway. I was giving a talk on Thursday. I mentioned to you earlier in the green room,
Right.
and I had a pediatric dentist that came up to me and introduced himself. He goes, "Yeah, yeah, I'm really interested, and I've been doing airway for a long time ago." And I asked him, I go, "Well, what's airway?" Well, it's, you know, it has to do with, you know, sleep apnea and this and that. I said, well, you know, maybe that might change after my presentation. And I hear that all the time. Let
Right.
me just say that, and this really underscores why the dental provider of all specialties, not just the generalist, and the pediatric or orthodontist, is needs to be involved. Okay, so what airway focused dentistry is all about, and why the dental provider plays the most key role, more so than the physician. Although the physician is important, we need to integrate and work with our physician counterparts, is that airway is really defined by our facial skeleton and how it's changed. And this podcast, we're not going to talk about it, but we will in one of the others, is the anthropology standard. Why is this all of a sudden going on? And we'll talk about that. I'll put that on the side, because that's one of the things that is an underpinning of our mini residencies, understanding and treating to an anthropologic standard versus to the current disease standard, right? So airway is about understanding what the functional space is represented by the airway that's defined by the bony skeleton of the splanchno which is the facial skeleton underneath the basicranium or the calvaria, has changed dramatically. And it actually is defining the airway from the tip of the nose down to and below the epiglottis from the dental medical point of view for breathing and sleep. Okay, so because certainly the aerodigestive tube continues infraglottic, but that's a different that's where pulmonologists start really working in that area. Um,
Oh, hang on a mark. Okay. So we got the pulmonologist, there are our medical doctor colleagues to deal with that area, basically the lungs up,
yes.
where they merge and up a little higher. But, wait a minute. I mean, we're dentists. Let's just stay focused on teeth and implants and we'll check out the tongue and make sure we don't have oral cancer issues and we'll look in the throat. But isn't that the ENT? Isn't that the ear, nose, and throat medical doctor that's really responsible for that upper area?
Well, yes, they have a responsibility for sure, as it's defined, ears, nose, and throat.
Okay.
But they don't really have the wherewithal in their training to really address it the way the dental professional does. There is no discipline in healthcare that knows more about craniofacial growth and development than dentistry,
Hmm.
and
Yeah, yeah.
specifically the orthodontist. And so this is really a growth problem that starts from birth moving forward through growth and development. That's a point, early intervention. The
Okay.
ENTs don't know they what to do other than maybe doing surgeries and maybe even the allergist dealing with things along those lines. But it's really the dental professional, of which the teeth are just one structure of a complex stomatognathic system is what we talk about, but it goes beyond the stomatognathic system. And this is what I'm arguing for, is
Hmm.
that we must go beyond the stomatognathic system that's representing the teeth, the gums, the joints. It's traditionally the way we were trained, but let's consider the bone that house those structures that, as it turns out, really is germanely related to flow limitation or how we breathe, the size of it, if you will, and that's growth and development. So our interventions, we can actually cure the problem. We could go beyond managing it with CPAP and medications. And I would say the earlier you catch it, the less invasive. But even late in the game, if we're going to cure it, beyond managing it with CPAP or even oral appliances, it's really the dental professional that has the biggest role. Double jaw surgery and corticotomies and things like that. So, but why would we do this? Is because there is flow limitation and somewhere along the line from the nose down to the epiglottis, it's about 25 centimeters. Okay. And so what we target very precisely are the kinks in the hose, if you will. The primary kink are in the nasal valves, right? And so what we know from a number of studies is that the way we could open that angle to decrease flow limitation is by expanding a transverse expansion of the nasomaxillary complex. Notice I didn't say the palate. I said the nasomaxillary complex.
Right.
We have to stop looking at. So when I talk to my patients about palate expansion, I'm not saying it's about the palate. I'm actually saying we're doing this to focus on the second story of that two-story home, which is the nasal fossa. Why? To decrease flow limitation. But it happens that form follows function, that as you make it wider, the vault of that tongue now can better house that airway dilator muscle that we call the tongue, which, by the way, the tongue's primary goal is not deglutition, swallowing, and speech. Those are important functions, but it's to dilate the airway at the oropharyngeal junction. We don't ever think about it in dentistry when we're in dental school. It was it was just something that was wet and got in the way of our work, right? But
Right.
actually, it plays this huge role in dilating the airway and actually helping our head be in the proper position relative to the torso. So, but if everything's crowded in, because the airway, the functional space that defines it, and it's defined by the bony structures, the 22 bones that make our head, then you have flow limitation that cause all the dental and medical comorbidities that we talk about in the mini residency that people are trying to address. But palatal expansion by itself is not really airway. It's a tool, certainly in the garden, if you will. It's the spade in your your toolbox to cultivate a nice garden, but it's not the tool. It's only one. And so we have to look at structure, function, and behavior, the breathing behavior. So the dental professional or provider has a responsibility of actually growing that face to its full genetic potential, getting it to where forward and downward growth, high cheekbones, big square jaw, moving forward to open the airway, as Donald Enloe would say. The airway is the keystone for the face. And gas exchange is the most important physiologic function moment to moment of any mammal. And nasal breathing is the way any mammal breathes moment to moment. And only us Homo sapiens, modern humans, can have oral tidal breathing and gas exchange because we have language, and we're not going to get into the details of that. But every other mammal can only exchange gas through the nose. There is no other mammalian species that can exchange gas through the nose, or they can, but they're usually in trouble.
Mm.
Like Harvold's monkeys back in the 70s, experiments that got those young monkeys that he sutured silicone plugs in the noses and they got sick. One of them died because they couldn't exchange gas to the nose and they ended up having long face. They were able to adapt, but they were all sick. And then they removed
Right.
it and they were able to be healthy again, but they never really quite recovered in their normal growth and development. So part of the experimentation is looking at the effect on growth and development. So we know how we breathe is
Right.
key to how our face grows, and it's just this spiral, if you will, that's all interrelated. So
Right. Well, let me interject there because
please,
I just got asked this just the other day about taping your mouth before you go to sleep and how that's going to be helpful. But if your airways are problematic and your valves are not open, is how could taping help if you're not addressing structure and function, you're just addressing behavior. So that seems somewhat limited. I just don't know much about this whole taping craze, but it seems to be quite the viral thing to do. Could you speak to that a little bit just before we
Oh,
move on?
100%. I'm glad that you brought that up, Richard. In fact, that was one of the questions at the end of my talk on Thursday that someone brought up in the back of the room and said, "Well, what do you think about taping?" I go, it's funny that you should say that. When I was talking about taping back in the day, probably 12, 13 years ago,
Yeah.
um, I, I, at the time I was trying different tapes like Scotch tape, and then I tried like medical tape, and they weren't that comfortable to kind of keep the lips together. It was never intended to be a solution or an answer to a problem to mouth breathing. It was just to understand the difference between being able to sleep breathing through the nose versus mouth breathing.
Hmm.
And I actually talked to a couple of thought leaders that were teaching on sleep and everything. And I talked to them, they thought I was crazy. They kind of looked at me and go, what are you talking about? And in fact, I was asked to be involved in and run an IRB study at the University of Chicago. Actually, it was Northwestern. Um, uh, back in the day, and the other PI, primary investigator, was an ENT, Robert Thomas. And I was designing the study, and we're talking about the different groups and the different interventions. And I said, what we should do is we should have a group where we're actually taping them and see how it changes oximetry. And he said, that's a great idea. And I remember because I'd invited a colleague to be involved and I won't mention his name, to be involved in the study, he says, are you joking? That's the dumbest thing I've ever heard. It has nothing, there's no evidence for it. So this is typically the type of response I would get on that. Where now you've got companies on the internet that are selling it. You have
Hmm.
people that are going out and teaching courses about taping, and this is what we need to do, and as if it's a solution, but they're missing the point. The point really was to understand how our lips need to be together as part of the five competences. Nasal breathing 90% of the time, lips together, tongue on the roof of the mouth, non-collapsing pharynx during breathing, day and night, and diaphragmatic breathing. This is the way we were designed to efficiently breathe. So if you're mouth breathing for whatever reason and you tape, it your oximetry, and people will say this, it will improve because you have nitric oxide that only occurs. It's an endothelial signaling molecule that dilates the endothelium. That you only have this transient signaling molecule produced when you're nasal breathing. It's not produced when you're mouth breathing. So it does actually improve oximetry short term, but it doesn't prevent your tongue from dropping back and obstructing. So you could tape all night long and it may help you, but it doesn't prevent your tongue from obstructing, which is really the bigger problem. And so I think taping can have a benefit to be sure, but really what you should be doing is myofunctional therapy to repattern and strengthen the orbicularis oris. So
Hmm.
it's the muscle. But there are two things to consider here since we're talking about it. If you are truly bimaxillary occlusive, and let's just look at a hyperdivergent, high angle, deficient mandible. If you look at the distance from the lower lip to the upper lip and a truly retrusive mandible, that distance is too difficult for that individual to maintain a lip seal mechanically. And when
Hmm.
they do bring their lips together, you'll notice they always have mental strain. So you're
Hmm.
asking them all day long to do something they just can't because mechanically it's too far
Right.
different. So that's a problem that the only way you can correct it is by orthodontic surgery. And I have routinely take images with a patient that is supine under general anesthesia before the surgery and after the surgery. And you could see they're just as asleep, that the lips are almost closed after the surgery, where they're quite open or way far back before the surgery. So the structural risk factor as it pertains to the triumphant of structure function behavior is addressed for sure. It makes it easier, but you still have to repattern the muscles and train them. And that's not just strengthening the muscles. And a lot of myofunctional therapists and people that are doing the myo are not fully understanding. And I've talked to many of them in the past about this. It's not just going to the gym and making those muscles stronger. More importantly, it's repatterning the neurology, what are called central pattern generators. And so what happens is it's like the myofunctional therapy, it's kind of like the way I describe it is if you've got, I don't golf, but let's say you have a bad golf swing, you want to have the ball go straight, but you're always slicing it. It's that muscle that it's the muscle memory of how you're swinging it at the last. Maybe you twist your wrist and it goes off to the side, right? And so a good golf pro will videotape it and they'll show you so you can consciously be aware of it. And then he'll tell you how you're supposed to do it. And you feel your hand on the club differently. And it's repeat, repeat, repeat. It's intensity, frequency, duration. Eventually you straighten it out to where you're not even thinking about it because your central pattern generator, your neurology now, and your muscle memory allows it to go straight. It's the same thing with shooting basketballs or throwing the football. It's neurology. It's not necessarily strengthening the muscles. A lot of people think that myofunctional therapy is just making the lips stronger or the cheeks stronger or the tongue on the roof of the mouth. It's all of that, but it's driven by the neurology. And that's what we call function. So, uh, so the taping is good as a diagnostic tool, is the way I'll say it.
Okay.
But you have to really address it with a root cause by getting
Right.
neurology. And if it's structural deficiency, you got to talk to the patient about. You got to correct that. Otherwise, you'll never be able to get. And a lot of patients are. I'll just say this one last thing: are frustrated because these kids get burnt out. They just can't do it. Parent comes in.
Right.
Well, it's because their jaw has to be developed as well.
Right.
And if you release the tongue before you developed it, they could get worse. So the sequence of treatment is super important. You don't just go out nilly-willy and releasing tongues unless it's an infant that's starting bottle feeding and it's a very different. But once you start in growth and
Right.
development, you have to recognize that maybe a tongue tie release is in the game, that's in the treatment plan, but you may have to sequence it such that let's just wait till we have a larger vault, you repattern the muscles, and then you release it, and then it's not going to drop back and make the airway worse, which that happens, by the way.
That makes perfect sense. And so circling back to this point of taping, if somebody has a significant, restriction in their nose, I would think taping would be impossible. It would be so uncomfortable. You couldn't breathe.
100%.
Yeah, so I mean, this blanket recommendation that taping is going to cure your problems. You mentioned the retrognathic jaw as being an issue. You mentioned the fact that it's much more complex than just closing the mouth off and closing the lips. And then if you move the jaw in the right position, the lips will naturally close, like you just that story after surgery, which is so fascinating. It's sort of where we want to be naturally. And so taping is uh, interesting from a diagnostic standpoint, but perhaps of little long-term benefit really for people. And we need to address higher level issues. Would that be fair to say?
Yeah, absolutely. And you bring up a
Okay.
good point. So, two things about taping and about nose breathing, because you could have flow limitation for a number of reasons. One, it could be a deviated septum, it could be enlarged turbinates,
Got
it could
it.
be just nasal congestion because you are have we're not going to talk about it in detail today. At some point, we will low end tidal CO2 that will
Mm,
cause swelling. So
right.
it's a physiologic or your autonomic nervous system is responding to that breathing pattern that causes congestion, or you could be sick, right? You could have
Right.
a bacterial
Allergies
virus, or
or yeah. Right.
exactly. So you could have all those things. So if you're taping, and I tell this to parents, you know, don't don't dare tape a child across the mouth until you really know what's going on. And I'm going to say, first of all, you might try maybe an hour before they go to bed or during the day. Can they hold their lips together? Do it
Right.
rhythmically so they're not freaking out. But the other thing is you could do a coddle maneuver. So
Right.
coddle maneuvers what the ENTs will do where they'll open the valves, right, to see
Right.
because it's
Yeah.
the nasal collapse, and you could see is there an improvement in nasal resistance. But
Hmm.
yeah, you're right. Even oral appliance therapy is very difficult. CPAP is intolerable if you have any of those uh, issues in flow limitation with the nose. So one of the things that we do with the kids is is the mouth breathing just a bad habit, or can they truly not breathe through the nose? And so
Right.
one way of doing it is what we call the 2 minute test. So you have the kid, you time them, you have them hold their lips together and see can they hold it for 2 minutes. And if they can't, you know that there's nasal congestion, there's something you have to address. If they can, or they get really fidgety, then it gives you information from which to treatment plan. Let's just put it that way.
Makes sense.
And maybe if they can hold it together, they could tolerate to start them on taping initially, just to train them on how they should be breathing. Because
Gotcha.
they have this mouth breathing that is classic of adenoid facies, first described by C.S. Tomes back in like 1872 or whatever. So it's not news. You know, this is a craniofacial pattern that's been well defined and described. Aaron Linderson in the 70s talked a lot about that back in the 1970s. I don't think they just really quite understood that it was really part of the airway issue the way we do now. So yeah,
Okay.
hopefully that answered about taping.
Yeah, that's fantastic. And so now let's delve into that. I don't know how to describe it other than you don't know what you don't know situation for patients. You know, the patient that is suffering from UARS, which I want you to explain, and they don't know what's wrong with them. And so many people are suffering from this, whether they have anxiety or depression or headaches, cold hands and feet, GI problems. They also, I mean, they can have neuropathies. We can look at uh, just brain fog, fatigue throughout the day. They don't understand it. Yet they're really driven people. These are a lot of these people that sometimes are the patients that I find are the ones that suffer the most, are the ones that are really successful. You know, I mean, all the way from we were talking earlier about professional athlete to the super mom that is, you know, running yoga courses and not just taking them, but teaching them and, you know, doing all kinds of incredible things. And yet really silently suffering because no one's been able to diagnose the underlying UARS issue. Can you speak to that a little bit?
Absolutely. I mean,
Great.
that's perfect setup. So let me just say that a lot of people may or may not know. So Christian Guilleminault, who essentially is the sleep physician that started the specialty with Remmers back in the East Coast, but back in the day, and before even it was a specialty, back in the 1970s, believe it or not,
Hmm.
Christian Guilleminault was looking at kids and he was using an esophageal probe looking at what's called flow limitation.
Right.
So he was actually looking at airflow in the nasopharynx. And so he would use a probe, and that actually was able to pick up much more sensitively events, breathing events, than an apnea or hypopnea. And so
Oh,
in
by the way, that makes perfect sense, by the way. It really does, because if you're just looking at the amount of flow that's going through that portion of the airway compared to a full-blown occlusion, I
yes.
mean, it's like we're talking about subtle little things compared to a sledgehammer, you know, and it was a brilliant idea to look at this, quite frankly, because it was, I don't know how he came up with it. It was very forward thinking, but it's
Well,
incredible.
I'll tell you how we came up with it. It's interesting because yeah, and if you look at a normal sleep study, you look at the electrode representing the tracking of the breathing. You've got like this almost this bell curve
Uh-huh.
bellows that goes
Right, right,
down, and then when you start having flow limitation, it flattens out a little bit.
right.
Flow limitation. versus
Right.
complete cessation, right? So
Yes.
you start looking start looking at those events, but they tended to ignore because you're still breathing
Right.
and so back in the 1990s, CG and Deepak Srivastava, who at the time was a research fellow in his fellowship there at Stanford, they started looking at these well, mostly females. What they did is in this particular study, there were 500 consecutive individuals that came in that reported they had like poor quality sleep. And what they did is they did sleep studies on all of them, the full level one lab sleep study.
Right.
And these patients invariably, this particular cohort, none of them had sleep apnea. And
Mm.
yet, Kristen Guilleminault knew that they were not lying about the reports of all the symptoms that you just outlined, that
Right.
otherwise get treated in isolation as separate things, not connected.
Right. Right.
And so he started looking at it, and what he found was in the EEG part of the sleep study is two things. One is during the time that the brain has deep sleep and three sleep, where you have slow wave delta, a brain pattern. The wave slows down and they have delta waves. What he found there in these patients in their profile is that they had what he called alpha intrusion. So the
Mm.
alpha wave is that brain wave that you have when you're awake and you're alert.
Right.
And he's saying alpha, and so he called it alpha intrusion. Like, what's it doing in the slow wave delta? It's the last place you would expect it to be seen. So he wouldn't see that in the OSA patient, the obstructive sleep apnea patient. He saw it in the UARS patient. And then the other thing he saw, without getting too much into the details, is what he called cyclic alternating pattern. That was a finding that you would see in the brainwave. Without getting into defining it, you could look it up. But these are two characteristics. And so that's what he used to define what he called upper airway resistance syndrome, that was different than the fat Pickwickian male that snored and had a 22-inch neck, right? That everyone was
Right.
focusing on.
Sure.
All of these patients were low to normal BMI, body mass index. So they were skinny or just normal body mass index. And so what he found is that following these patients 6 years later, and they all had the classic symptom profile that we call the functional somatic profile. That's anxiety, depression, headaches, TMD, irritable bowel syndrome, things that have to do with the autonomic nervous system. What he found was that they all suffered from this, and he defined upper airway resistance syndrome, and he wrote that classic paper. Fast forward maybe 20 years later, Avram Gold, a well-known sleep researcher from Stony Brook in New York,
Right.
kind of argued a little bit and really stirred the pot in the world of sleep medicine in a meeting. And he said, I see everything that Kristen Guilleminault is saying about what upper airway resistance syndrome, alpha intrusion, and a cyclic alternating pattern or CAP. You know what? I'm not buying it. You know what?
Hmm.
It doesn't really explain to me all those symptoms. Those are just labels to findings that are defining a condition, but it doesn't
Mhm.
explain why they have it. So he actually talked about and defined it that it was related to the autonomic nervous system and how it was functioning. And so he stratified these two populations where the upper airway resistance syndrome patient actually had a very active vagal response or parasympathetic response that the sympathetic side represented by the obstructive sleep apnea patient did not have. So the two very big differences is that the UARS patient has a hyperactive parasympathetic system, rest and digest, versus the OSA patient that is fight or flight, OSA. And so he started stratifying it. So if you have a very hyperactive vagal response. As soon as you start getting a spike in your blood pressure, your heart rate goes up, it immediately tries to solve it with a very robust parasympathetic response that drops the blood pressure. In fact, that's one of the characteristics of the UARS patient is they tend to be hypotensive versus the OSA patient is very high, tends to have a high blood pressure. So those are some physiologic differences, and we can get into a lot of the details
Right.
of that.
Right.
But those are some classic differences, and we get into all the details of the profile in the mini residency. But that's kind of the classic. And so as a
Right.
result of that, the UAS patient tends to appear not sick because
Right.
all the things that the physicians look at, like hypertension, atrial fibrillation, arrhythmias, and the weight gain, all those things that are disease management, the UARS patient doesn't have. It's like they look like they're a vision of health. And in fact, I'm going to argue that our profession and dentistry mistreated this entire population for decades. And now it's starting to come out from the pain management, TMD specialty, and others that um, breathing and sleep is important. And so what happened is these are the patients all of us know who got into occlusion and ethology and dealing with these patients with splints and all that and all the occlusion wars that argued over it that we thought that these were the case that you were typically female, young to middle aged. They were like the high functioning, like they were like always pains to deal with, right? And we said, you know what, you need a chill pill. You're
Right.
depressed. You've got to, these are the patients that when the phone rang and they were coming in, we'd see them on the schedule going, oh, I don't want to see that person. They're just going to just wah, 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 wah. They had the TMJ problems, the TMD. Well, we just missed the boat completely. These are
Right.
the UARS patients, and because they had a very viable autonomic nervous system, um, paradoxically, they were very symptomatic and they were able to express that they had these symptoms, and we would just give them a piece of plastic to help them with their night grinding and their clenching, and maybe it helped to some extent. We thought, okay, we got them a little better, but what that did is allowed their condyles to maybe come down and forward a little bit so that they weren't distalized. The muscles relaxed a little bit. You stopped that neuromuscular release. So we were right for the wrong reasons, without getting too
Correct.
much into that.
Correct.
Whereas the full-blown OSA patient, they had one foot in the grave. They didn't even know how bad they were because the right side of the cerebellum was damaged early due to chronic intermittent hypoxia early and often. The dorsal motor nucleus, which is the last relay, afferent relay to the brainstem to tell them that they were in trouble, that was damaged, which by the way also was predictive of type 2 diabetes, obesity, and all kinds of problems. And of course, things that we get into in the mini residency. So very different populations. But now that we know that is the largest swath in the population that dentistry can treat, that is separate from sleep apnea, which really the sleep physicians, because it's end stage, it's like an end stage disease, like metastatic cancer. We need to have our physicians deal with that. I don't want us really dealing with those patients because they don't have really as good a prognosis long term. Whereas the young to middle-aged female that has UARS, they're screaming for help. And in fact, in this study that Gimeno did, he found 67% of them were female. They were all low BMI. That 6 years later, over 90%, close to 95%, were unable to get access to care by the physician or dentists. 6 years later, because no one understood it. And so now we understand that these are our patients that want a nice broad smile. They have wearing teeth. They've got TMD problems. They may have the beginnings of some reflux. They have hormonal dysregulation. They're always on edge, and that they're being managed with anxiolytics and antidepressants. I want them off of that. And we
Right.
can get them into parasympathetic coherence by getting to them to downregulate their autonomic nervous system that's screaming at them because they have flow limitation. And it happens time and again. Once you get that flow limitation addressed, they sleep better. They wake up refreshed. They're always in a good mood. Things that we see also with kids, right? The neurocognitive correlates, they're just
Sure.
better. They're not breaking their dentistry. We
Right.
need restorations with higher flexural strength and fracture toughness. We need them just to not put their teeth together because they're in parasympathetic coherence. Just the way they feel like at the end of their yoga, right?
Yeah. That's amazing. And I wanted to ask a few questions that
Sure.
were kind of came up in my brain as I'm thinking about and hearing you. Uh, Where is the typical flow limitation occurring anatomically in the UARS patient, or describe that for me, uh, and compare that to OSA? And is it different than snoring, or may it have snoring at the same time? In other words, where is the kink in the hose? Can it be multiple different places with UARS patient, or is it typically in a certain portion of that 25 centimeter pathway?
Well, let me just say that that flow limitation is the same for UARS and OSA. It's just that OSA's end stage. It's just progressed to that point. It was always the
Ah,
same constriction, and it could be in multiple sites. It could be in one site. So, and
oh,
snoring,
okay.
let's talk about snoring. Snore could be, you can have nasal snoring, you can have oropharyngeal snoring. So think about this. So snoring, the typical oropharyngeal snoring that everyone says is like a chainsaw is as a result of a collapsing airway due to airflow turbulence that causes vibration in that tissue, and that energy creates a sound that we perceive as a snore, which, by the way, also is what causes the neurogenic damage to the mechanoreceptors in the back of the throat, the oropharynx, the tonsillar pillar, the uvula, and the soft palate that signal the brainstem on flow or airflow patency. So those nerve endings are damaged over time. So snoring over time causes a neurologic damage locally, and as well as the reflux that comes up that may or may not be recognized. So you have mechanical and a chemical intrusion risk factors to kill those nerve endings. So that's the classic snoring. And in fact, we also know that that vibration causes precipitation of calcium at the carotid artery as it's going by the throat. By the throat, you could see that in even a panorex. Oftentimes, you'll see the carotid
Sure.
calcifications because it's
Absolutely.
precipitated out, and that's when you send them out for a calcium scan. And I see that all the time.
Wow.
That's kind of a little bit of a sidebar, but the nasal snoring can be also because there's flow limitations, so they're kind of snoring up here. The main starting resistor, which is what we call the kink in the hose, is the nose valve, and that's usually because everyone is too narrow. Most of us now, globally, worldwide, are too narrow. We cannot expand a patient to a number as is recorded in the orthodontic literature because it's just wrong. Okay, so McNamara says 37 to 39 millimeters is kind of a good number. Actually, that's narrow in comparison to anthropologic standards of how we were just 500 years ago. And there are digs and showing that. And in fact, we have a study that we're going to publish exactly on that, where I'm expanding to 45, minimum 40, 41 millimeters to 45, 47, believe it or not. And it looks great. And we could talk about, why that's so, but it's not because of the intermolar width, it's because of the nasal fossa. I want to get that flow limitation down so that they're breathing easily. We want some resistance, but we don't want the resistance that you become aware of. So when you're breathing and everything slows down, there's some turbulence that we want,
Right.
but not enough to create a snore. So that's number one. And that's where our interventions, whether it's a MARPE in an adult or regular RPE in a 5-year-old, is actually to improve airflow limitation. There are a number of studies actually showing that actually go back to the 80s out of the orthognathic literature and later in the last 10 years in the sleep literature. But this is old stuff. And that's how we also plan our orthognathic cases. But you open the angle of the cartilage, the nasal valve, and then everything then calms down. And by the way, I tracked this with a high resolution pulse oximetry, and just doing the expansion at night, you could see the heart rate drops 10 to 15 beats per minute because the autonomic nervous system down regulates. That doesn't have to work as hard. And that's where you get restful sleep and you feel better because you're able to get into deep, deep sleep because the autonomic nervous system is not arousing. And then you get restorative
Right.
sleep through 3 to 5 minutes.
What it is a flow limitation. It's not apnea. There's no closure, but the body has enough ability to sense that there's a lack of flow that it would desire.
Yes.
And the only response that it really can make while you're sleeping is increasing the heart rate. Is that being done to help get more oxygen into the system? Because my understanding is that these patients don't desaturate in their oxygen very often in a significant way. They don't desat, but their heart rate is all over the place.
Yes.
Can you explain that?
Yes.
I have a little disconnect on that, and I want to make sure I'm really clear on this.
Yeah. In fact, let's end our podcast on this because we
Okay.
want to keep it to an hour. And we'll pick it up
Yeah.
but later. But I think this is a really good way to end the podcast discussion here. So first of all, to be clear, with the UARS patient, largely these are non-hypoxic events, something
Right.
that Kristen Guilleminault found in these kids in the 1970s. What he found was that there was flow limitation, but because they have a healthy autonomic nervous system, the autonomic nervous system was doing the primary job, which is preventing the intermittent
Desaturation.
hypoxia, right?
Right.
The desaturation to protect the organs. So
Makes
it was
sense.
doing the wrong, but it just came at the expense of the sleep because the upregulated sympathetic drive, right? So they never
Ah,
really desaturated. So it's all about the autonomic nervous system, and it's really like Ron Harper from UCLA Brain Research Institute told me many years ago. He says, what's killing the patient is not so much the intermittent hypoxia, it's the body's response to it.
got it.
The spike in the blood pressure and that the autonomic nervous system is trying to quell. So someone that's very healthy has a good high heart rate variability. It's its own discussion we could talk about in another podcast, heart rate variability. But
Yeah.
that means that the autonomic nervous system is viable enough to be able to mount an allostatic response to a threat.
Right.
The
Right.
UAR, the OSA patient has
They can't
lost
do it.
due to brain damage,
It's
and that's
done.
why they're in danger of having a heart attack because
Right.
the circuit breaker is not working anymore.
Got
And
it.
so you could see in that pattern, the native heart rate is lower of the UARS patient, but they have these big spikes where the heart rate's going up to 100, 120 beats per minute, comes right down because they're
Right.
healthy. Autonomic nervous system's not letting them stay up there. UARS patient, they'll meander, they'll stay up there. And that's when you have a stroke or a heart attack.
Hmm.
So
The OSA patient.
the OSA patient.
Right. Okay.
So those are the differences, and maybe we could think about this in one of our next podcasts. We might even show up some title slides and show
Okay.
so people can actually visually see it. But for now, why don't we conclude our discussion, which I think was great. I mean, this
Yeah. I do.
went
I think it was
so
awesome.
quickly,
Yeah.
and there was a lot for us to go through, and so I hope we were able to at least scratch the surface, and we can go on, and we will
Yeah.
through our podcast. So, but thanks for all those fantastic questions. I hope that it adds some clarity, and I think if people want to learn more, and I really think that what's important is that there's a standardized physiologic, data-driven approach to dealing with what we started defining as airway. What we just talked about is airway. And you have to have that understanding. You can't just go out there and start selling widgets because it's not a widget driven approach. There's a lot and this is why physicians won't respect us. If we just are all about giving an appliance and we call that airway, it's much more complicated and we own this domain. We're the ones that know what to do and what we can do about it. And we'll continue to talk about that. So
Great.
Some
Clearly, we do
rough
own this
area.
space. Yeah, we clearly do. I mean, it is, a lot of people are really worried that this is somehow not dentistry's wheelhouse, but you've made it really clear that this is exactly our wheelhouse, and it's just taken us some time for us, a lot of us, but not enough to realize this is the right way.
And Rich, I mean, wouldn't you agree? We're all trained on the physiology. We're doctors,
Of
but we tend
course.
to want to be mechanics because we can monetize that. The
Yeah, that's true.
plumbing, the implants,
Yeah, yeah,
surgery, and
yeah.
so we've stopped the thinking doctoring side of it. And of course, our patients are kind of, we've trained them like, it's implied, it goes along with
Right.
the therapy, or the intervention, that the diagnosis is there. We just need to be more physicians in that regard. With that said, Richard, tell us what's the learning lesson this week that you might bring up in closing our podcast.
Yeah,
Anything
I get a lot of emails, a lot of advertisements for courses and things like that. And I received an email of a course that was 100% widget driven and sleep focused from a specialist in oral facial pain that was promoting the course. And I happen to know this individual. And uh, the thing that was so fascinating to me is here's this uh, specialist, uh, obviously some acclaim in publications and things like this, teaching a course to dentists, and her physical structure was consistent with an untreated UARS patient. And I was like, oh my gosh, this is like the poster child of an airway problem untreated, and she's giving a course in airway and sleep. And I thought that was just sort of ironic. And well, I think she needs to be our patient, I think we need to take care of her. So it was just sort of interesting. And I think the learning moment is we see it everywhere, and we have to work really hard, really diligently to inform our colleagues, inform the public, probably simultaneously, that this is not, it may be normal to the point where we've almost accepted this as the way faces should look. It's so interesting, isn't it? And in fact, we know that is not the truth. We've become this way because it's been a pathological epigenetic change. It's just what's happened as a result of many factors. That's a whole nother podcast, and that'll be a mind blower to get into that one. But I think that's the learning moment I had. And
Yeah, it's funny. It's like you say, and people will say this, and my patients will also say this. This is, oh, they walk away with this. Once you see and understand the airway problem, you can't not see it, and it's
correct.
everywhere. So I would just be careful to say, probably all of us have airway problems giving courses, but at least we know it though. That's the
Yeah,
difference. The difference is you know it and you could do something about it. The irony
right.
is when you're giving a course and you don't know that you have the condition that you're going to be talking about. And that happens all the time, again, because it's so common.
Fascinating.
Because it's common, it's normal. It's like type 2 diabetes is normal, isn't it normal?
Right.
ADD
Right.
is kind of normal, right? You just fall into that. And we've kind of gotten to accept that because we're, again, in this disease management healthcare system. But I think our goal with this podcast is to really raise awareness
Yeah.
about something that's pretty complex, but make it very understandable and more aware, and also understanding with a good dose of humility what we don't know. So what we want to say is we want to go in there and continue to learn from each other, and really help society as a whole in addressing what I think is the nexus of health, which is our airway. I mean, gas exchange is the most important physiologic, and just because you're breathing doesn't mean that there isn't an issue there. And that's also what makes it confusing. Well, we're breathing, right? So what's the problem? But that's a really good pearl of the week, if you will. And we'll end with a little. You started the podcast with a teaser of what we're going to talk about next week. So what are we going to?
Oh
You guys
my
going to talk
gosh.
about next week?
Well, We're going to miss you, Mark, but I'm going to meet with Barry, Dr. Barry Raphael, and he's an orthodontist and an expert in treating airway issues of all ages, but particularly in our kids, our children. And I, I think that what we're going to delve into is how can you help your children become the best that they can be? And even if your student is an A student, maybe that he should have been an A+ student. Maybe if they, get some award for intelligence or something, some achievement, maybe it should have been a higher level. So we can always help our kids achieve their best. And a lot of kids are really suffering where they're not even close to their true potential. They're really having a tough time with life, with school, with behavior. They're driving families kind of crazy. And Barry and I are going to get into how to unravel that, unpack that. How do we look at kids now in the airway space and see if we can help them become better versions of themselves? And as a parent, and you and I both have got kids, this is so critical. So very exciting session next time we meet next week. So I'm really looking forward to it.
Yeah, well, I couldn't think of two better people to be able to really talk a lot about that particular topic next week, and both of you will have a lot of insight, and yeah, I think early intervention is important. It should be a standard, and until very recently, that just didn't occur. And I'll just say we know I see the mama bears coming in all the time. They're frustrated with the pediatricians. The pediatricians aren't asking anything about sleep, certainly breathing. They're
Right.
asking, what vaccines have you had?
Right.
The pediatric dentist is more worried about caries and strip crowns and maybe an occasional space maintainer of some sort. And then the orthodontist really doesn't really, until recently, doesn't really want to see the kids till they're in braces age, which is too late. That's at the end of mixed dentition. At that
Right.
point, it's a fait accompli. At that
Right.
point, it's much more difficult to undo it. Now, you could straighten the teeth out, just like you could get the chairs on the top deck of the Titanic, nice and neat rows, but that ship's going down.
Yeah,
So I think
that's
you
so
guys should
true.
talk about really, again, the medical comorbidities, really what should be driving it. And a lot of parents just don't know. They need the help, they need the support, they need the docs to really ask those questions. You ask them, well, how do they sleep? Well, they sleep okay. They don't even look in the bedroom. And so you guys will get into it. I'll miss you guys. I'll see you the following week, but I'll look
Wonderful.
forward to listening to your podcast. And thanks, Rich, for another great podcast, and
Thanks, Mark.
we'll sign off and have a
All
great
right.
rest of your week. All right, take
Okay,
care.
buddy. Take
All right,
care.
take care. Sounds great.